Betul kan? Kita orang more than 100, tapi kita orang buat satu link yang masuk link ni, so that another link tu dia boleh masukkan orang-orang yang terlebih tu lah, doktor.
Okay. Alright. Okay, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. We'll start our session with Umar kita Al-Fatihah. Alright, so thank you Adin for organizing this. Sorry again, this is actually a delayed session. It was supposed to be some times ago, but due to some problems we have to postpone it today. So Alhamdulillah, and I just realized that you had back-to-back session for psychiatry this afternoon. So I'm not sure how much more can you absorb in 3:30 in the afternoon for common lecture like this. Macam tadi saya join in kelas Dr. Hanisah earlier on, just to do some mental state assessment on all of you yang tengah tengok, and ada yang nguap, ada yang tupang dagu, ada yang buat-buat macam faham, so macam-macam mental state saya find out. So okay ke tak ni nak proceed with another topic ni?
InsyaAllah doktor.
InsyaAllah. Yang nak okey ke tak okey ke, kena okey jugalah. Kalau tak, celah mana nak cari tarikh lagi kan. So anyhow most of you are resting nicely at Mahala at the moment, betul kan? Semua orang tengah beristirahat, betul tak? Ni semua salah budak dak surgery lah ni kan. Kan kita yang psychiatry mana buat salah apa, betul tak? Kita duduk relax je kan, belajar dengan Dr. Nizam. Tiba-tiba kena duduk mahalah pula. So anyhow, that's how life is, and so just accept it the way it is. Semua orang okey ke?
Okay.
Okay, betul. Dan daripada bunyi tu saya rasa macam tak berapa nak okey tu. Dia macam tak berapa ikhlas. Dia tak full force. Alright, so kita carry on. So anyhow, I know a lot of uncertainties, especially with your batch ni, but anyhow we'll carry on. Kita take it apa yang ada. Okay, so like wise person always said, life ni ada dua benda, dalam hidup kita ni ada dua benda. Satu benda yang kita boleh control, satu benda yang kita tak boleh control. Okay, so acceptance, redha, is accepting that certain things are beyond our control. Courage is to have the ability untuk change apa yang kita boleh change, and wisdom is ability untuk differentiate between those two lah. Okay, so whatever happened to your posting and your attachment and your clinical classes are essentially beyond your control, in fact beyond our control. So what's beyond your control is what you can do with the rest of your time yang you ada dekat mahala lah. So I hope that you will spend this time wisely, do whatever necessary it takes untuk you catching up. So even though everything is online, for some reason more students are getting distinction, especially for psychiatry posting. I blame it to the marking scheme, tapi anyhow it's a good news for you all lah. And so when I was presented the number of students who get distinction tu, saya yang number one object lah. Tapi anyhow, that's how the assessment is masa ni. Kita adjust to what we have. Yang penting at the end of the year, at the end of this year, my sincere hope is you'll be able to come out of UI ni as a good doctor lah, insyaAllah. So good doctor ni doesn't come with wisdom, dia datang dengan effort lah. So one of the effort is for you to stay awake during this class. So kelas hari ni akan slightly different. So like any other classes that I have, kita akan approach it in exam oriented. So the topic is Adolescent Psychiatry. It's a new topic for your batch, something that we haven't specifically covered master posting. Tapi kita akan use this example or this discussion untuk you refresh some of your knowledge in psychiatry posting that you had lah. So for those who have passed, for those who have undergone psychiatry posting, this is a refresher class for you. For those who are doing psychiatry at the moment, so this is possibly something yang I can adding on to your psychiatry knowledge lah, insyaAllah. Okay, next. Okay, so kita akan discuss case. Okay, so from the beginning until the end, kita akan discuss this one particular case. So it's a real case. In fact, patient is my own patient. Patient is still currently in hospital. So we'll see what we can discuss along the way with regards to the case lah. So patient ni is a 13 years old. So along the way tu there will be questions, just like how kita buat practice PMP and so on before this. So I'll call up names. So semua orang kena get ready dengan microphone. So delay more than 3 seconds tu out dah. So delay and answering more than 3 seconds tu nak capai telekong ke apa semua tu dia unacceptable. So terus answer because we have plenty of questions, kita nak cepat. Okay, and you can jot down the important details of the history because kita may not be able untuk back and forth with the slides lah. Okay. Belum apa-apa Hazrik dah left dah. 13 years old Malay boy from Kuantan. Second child out of 2 siblings. Attended with his mother to psychiatric clinic with presenting complaint of change in behavior for the past 3 months. So he was described as socially withdrawn with refusal to go to school. Weh, Mohana left dah. Siapa nak jawab soalan ni? So refuse basic self-care, irritability, and problems actually gradually occur gradually over time, but worsen over the last 2 weeks where he started to becoming irritable whenever family insisted that he go to school. Okay, so the presenting complaint is number 1, social withdrawal. Number 2, refusal to go to school. Number 3, refuse for basic self-care, mandi, pakai baju. So semua need a lot of prompting. Irritable at times. Problems occur. So all of the symptoms ni not really sudden. It occur over insidiously over some period of time, over 3 months. But the last 2 weeks worsen. So prior to see, patients have been brought to see Ustaz, Bomo and whatnot in order untuk improve dia punya symptoms, but he did not improve. So eventually dia came to see me. Okay, next. Okay, so questions number 1. So whenever you're presented with any problem, especially with regards to psychiatry, very fundamental questions. Are these changes in behavior normal? Yes or no?
No.
Siapa?
No.
Okay. Siapa yang jawab tu kena beritahu normal, saya tak nampak. Amalia, normal ke tak normal?
Tak.
Okay, so why do you think it's not normal? Why do you think it's not normal? Biasalah budak 13 tahun kadang-kadang tak nak suruh mandi, tak nak payah mandi, suruh semayang tak nak, lepas tu suruh pergi sekolah, nak pergi main dengan kawan lah semua tu. Okay?
Biasa, tak biasa kot.
Tak biasa, awak budak baik. Memanglah. Kalau tak nanti laki awak marah. Tapi kalau you fikir budak-budak dekat Ulu Tembeling sana ke, budak-budak dekat Felda Keratung ke, 13 years old sometimes tak nak mandi, tak nak pergi sekolah, tak nak pergi mengaji. So can that be normal behavior? So Amalia, you rasa it's not normal? So why is it not normal?
Because I think at this age, biasanya the kids akan play around with other friends. Then bila they start to have social withdrawal and irritability too, might be some psychopathology behind it. I don't know.
Okay, apa key points yang you rasa it's a pathology, it's an illness, it's a problem?
Social withdrawal.
Okay, social withdrawal. Lagi?
And
Tapi have you not have you not met teenagers or have you not heard teenagers yang memang jenis yang tak nak ikut mak keluar, tak nak main dengan kawan, duduk dengan headphone, main game kat bilik. So that can also be a characteristic or description of a typical adolescent. What?
Yeah, possible, especially in current situation.
Okay. So what make it not normal?
I think it is too long out there. For 3 months, I think it is too long.
Okay, yang acceptable berapa lama? Okay, Arif. Yang acceptable berapa lama?
Oh, I'm not very sure. Sehari 2 je biasa tu.
Sehari 2. Okay, sehari 2 kalau tak mandi tu biasalah kan. Sejuk gitu lah, air tak ada. Kalau 3 bulan tak boleh terima. Okay, alright. So, number 1 untuk kata normal atau tak normal adalah we need, number 1 is a good understanding of what's normal for that age. Okay, so this is a basic, maksudnya this is a basic guide ataupun yang guide yang selalu saya sebut whenever you join my psychiatry clinic. For example, if you have 1-year-old who presented with difficulty in cooperating with the sibling. So, normal not normal?
Normal.
Dia tak nak share dengan adik-beradik dia, dia marah bila abang dia pakai topi dia marah kawan dia ambil dia punya Beyblade. So, that normal not normal? So, that's normal. Okay. Okay, tapi for 8 years old and refuse in any way untuk cooperate with any other children, so that's not normal. Okay, so number 1 gauge yang kita perlu guna in order untuk kita ascertain sama ada this is normal or this is actually part of symptoms adalah appropriateness to the age. Okay, so kita tengok apa sekarang? Social withdrawal. So playing, maknanya social, being social at 13 years old ni apa yang normal? Socially, apa yang normal for 13 years old?
Playful.
Playful? 13 years old ni dah nak start masuk adolescent. Socially dia dah start ada gang, tu tak? Dia dah start ada clique and dia dah start bonding dengan certain group of gangs. Okay, so that's what's normal. So kalau dia socially withdrawn, dia tak nak belong to any group, then that something's not right, not appropriate to dia punya age. Okay, refusal to go to school. So with regard to school, 13 years old biasanya apa? Ada lagi tak issues with tak nak pergi sekolah ke, separation anxiety ke, school anxiety? Should there be any problem?
It can be.
It can be.
New environment,
okay, alright.
Secondary.
Okay, so it can be normal, it can be not normal. So depending on the situation. So in this case, so he has always been in this school, and so for the first part of the year there has been no problem until these 3 months. Then that means it's no longer normal to the context of the presentation lah. Okay, and refuses basic self-care. 13 years old self-care macam mana? Dah 13 years old macam mana awak dulu? Dah start dah pakai deodorant ke wangi-wangi ke? 13 years old dah pandai dah kan letak pas tudung tu mesti jahit dia betul, dia mesti gosok, dia mesti line dia betul. So dia dah start dia dah start concern about that. So 13 years old dah start concern pasal dia punya self image. Kalau in psychological term, during adolescent ni dia panggil dia ada imaginary audience. Awak pernah rasa tak imaginary audience? Orang tak tengok awak pun, tapi awak rasa macam yang buat aku ni kena betul ni, nanti kan ada orang tengok kan, Adin suka dia. So perasan poyo kan? Bukan poyo, tak, maksudnya any normal adolescent, part of dia punya development, in order untuk dia develop dia punya self esteem, dia kena ada this one stage where dia akan living with imaginary audience. Maksudnya dia always conscious of dia punya hair. Kalau you ada adik umur 13 tahun tu, you usik sikit rambut dia jadi kusut-kusut sikit, dia terus betulkan, betul tak? Padahal tak ada orang tengok pun, sebab dia concern, tak tahulah tiba-tiba melintas Atikah ke melintas depan dia ke, Iqlil ke melintas depan dia ke. So dia kena concern. pasal dia punya appearance. So basically what I'm saying is, number one clue adalah the symptoms that patients display ni is not typical of dia punya age presentation. Okay, that's how you know it's not normal. Second adalah you compare dengan dia punya baseline. Alright, so of course you need to have some idea pasal macam mana dia punya baseline. So kalau dia daripada kecil, dia memang socially withdrawn, contohnya budak ni ada autism, so it may not be something yang worrying. And tapi of course in this story, you dah given information that the problem actually started 3 months back. So it wasn't something yang way back for years. So it only become problem 3 months back. Then you know something's not right for the last 3 months. Maksudnya something has altered dia punya normal equilibrium of dia punya psychological state, menyebabkan something happen. Alright. Number 3, the clue for you to know whether it's not normal or not adalah you compare the symptoms yang dia present dengan set of problems yang normally happen in psychological or mental health issues. Now, for adults, and saya selalu sebut, normally, typically, presentation akan falls in 1 out of 3 pattern of presentation. Ingat kan? So 1 out of 3 ni apa? Number 1?
Cognitive.
Mood. Number 2?
Psychosis.
Psychosis. Number 3? Anxiety. Okay, so whatever symptoms yang patient presented with, think along this line. Could this be psychotic related? Could this be anxiety related? Could be depressive related? Now, for children and adolescent, dia punya grouping of symptom tu slightly different. Okay, so grouping of symptom tu ada 4. Number 1 apa? Kalau children, number 1 apa? Yang most of them are in my clinics, apa dia?
ASD.
ASD tu diagnosis. Dia punya group.
Neurodevelopment.
Number 1 is neurodevelopmental related problems. Number 2, besar sikit apa? Besar sikit apa?
Mood
disorder.
So emotional related. Okay, emotional related maknanya kita include sekali mood dengan anxiety. So emotional related. Number 3, tadi ada someone mention apa? Tak nak pergi sekolah, menipu, lying, bully, behavior related. Okay, so under behavior related ni you ada conduct disorder, positional defiant disorder. Okay. Number 4 adalah a more serious mental health problem yang presented during adulthood and during childhood. Contohnya childhood onset bipolar disorder, childhood onset childhood onset psychotic disorder. So dia punya differentiation is slightly different. So whenever patients, children in adolescent group presented to clinic with some set of psychiatric problem, you need to be thinking along this line. So could this be neurodevelopmental? Could this be emotional related? Could this be behavioral related? And could this be other serious mental problem? Okay, then from there you can derive some possible differential diagnosis. Alright, now before that, before you understand about possible differential diagnosis that you can think of, what also important, additional to child and adolescent punya specifically in child and adolescent punya context adalah you need some sound information or some sound knowledge with regards to developmental issues in this age. Maknanya apa issues development in this stage. So what are examples of developmental issues in this stage? Tu. Siapa lagi yang dah sudah clear? Kita tanya yang dah buat psychiatry. Apa developmental issues? Tak dengar clear. Sorry? School refusal. Kenapa adolescent ada developmental issues? School refusal. Apa developmental domains of adolescent? Kalau in children kita bercakap tentang apa developmental domain in children? Kita bercakap tentang apa? Kalau children? Amira? Lama, geng-geng yang dah lama tinggal psychiatry ni kita tanya sikit. Lebih dah 3 saat dah ni. Cepat.
Tak
Amira?
sure.
Tak sure. Apa developmental domains of children? Kali saya suruh awak datang balik klinik child saya betul. So when you assess child, apa developmental domains dia? Apa domain saya nak tengok?
Social.
Social, okay, good. Lagi?
Speech.
Language. Lagi?
Physical.
Physical. Lagi?
Language, social, emotion.
Okay, so social, emotion, language, physical, and fine motor, gross motor. Okay, so roughly around that lah. Okay, tapi kalau adolescent, kita tak tengok dah fine motor, gross motor. You tak suruh adolescent mari klinik, cuba adik lompat sikit. Tak ada, you don't ask adolescent to melompat-lompat dalam your clinic. So in adolescent, apa domain of development yang kita tengok?
Education.
So education, so basically cognitive, okay, correct. So you want to know their cognitive development. Lagi?
Social.
Social. Apa yang paling penting masa adolescent, what happen? You all ni kan macam tak pernah jadi adolescent, beranak-beranak 24 dah ke?
Role confusion, doktor.
Puberty, yeah. So don't forget, one of the important developmental stage that occur during adolescent is physical changes, in particular sexual changes. Okay, so physical changes, cognitive changes, and then you have psychosocial changes. Next slide, apa nama? Adin? So these three domains ni yang important for you untuk explore, and you need to know apa yang normal and what's not normal during this stage. Baru you boleh relate sama ada apa yang this patient experience, whether it's something normal or something yang not normal. Okay, next. And one of the issues yang we need to highlight during adolescent adalah the fact that the adolescent ni are in borderline. Okay, in borderline ni meaning say they are not yet adult, but they want to be adult. They are no longer children, but they want to be children. So they are somewhere in between. In fact, adolescent ni concept yang relatively new, and before this we don't really have concept of adolescent. And in fact, in Islam pun kita tak ada really specifically a concept of adolescent. And apa yang kita ada at one point mumayyiz, and another point balik. And once you balik, basically you dah you punya role and responsibility tu almost equivalent to adult. Okay. Alamak, ada phone call. Kalau saya jawab, saya drop lah kan call ni kan. Tak apalah, dia letak dah. Okay. Alright. And so the continuous development of adolescent brain ni is one of the fundamental things that contribute to a lot of emotional changes that happen during adolescent. And so they are emotionally and physically and mentally incomplete in a way that some of the function of the brain tu has not yet reached its maturity. Umur berapa brain kita reach maturity? Maksudnya dah tak ada lagi new development, tak ada lagi new almost plateau in term of dia punya wiring dia. At what age you rasa? You all umur berapa 28. You all umur berapa?
25.
Tua dah. Okay. So, until what age kita punya brain ni still developing?
Is it 21 years, Doctor?
Any other guess?
25.
25.
30.
25.
So sebenarnya 25. So you all ni at the last stage of your brain development. Lepas ni dia akan start atrophy dah lah. Slow macam otak saya ni. Okay, next slide. So optimize your brain wiring masa 25 ni. So do whatever it takes untuk complete the wiring Okay, next stage and next slide. Okay, so next slide you will see this neuroimaging of brain functioning. So it's a functional imaging of brain. So apa yang saya nak highlight dekat situ adalah one particular part yang responsible to executive function and ataupun areas of the brain yang responsible untuk govern kita punya emotions, feelings, behavior, socially, executive function, which is dorsolateral prefrontal cortex. So gambar tu dia tunjuk color tu in accordance to maturity. So the more bluish it is, the more mature it is. And so what you can appreciate from the image adalah even though the brain at the stage of teenagers, the rest of the brain are already bluish in color, maksudnya dah almost mature. Your parental lobe, your occipital lobes are already bluish, mature in color. Tapi if you look specifically in the small box, which is the location of prefrontal cortex, you'll see it's still green. Okay, so basically the neuroimaging highlights that this part of the brains are last to develop. So that's why in some studies they discuss along the issues of for example, next slide dia ada cerita tentang vulnerability of adolescent, and which means basically explain some of the behaviors of the adolescent. Contohnya, some parents complain kenapa anak dia ni susah nak basuh pinggan, kenapa anak itu. Siapa yang join my clinic earlier on tadi, dengar mak, ada seorang mak bebel cerita anak dia tak nak tolong, anak dia tak nak tu, anak dia tak nak ni, dan anak dia tak rasa apa-apa pun. Anak dia rasa macam, dah lah doktor, saya tak ada rasa nak buat. Anak dia cakap macam tu je. Anak dia around 22 years old. Okay, and so one of the reason adalah dia punya problem in executing, and problem in prioritizing, problem in judging other people's punya emotion. Dia tak boleh fikir yang mak kita ni susah, mak kita dah tolong kita. So all of that abstract concept is still not yet fully developed, and resulting in some of the behaviors yang what we perceive as immature. Okay, another important highlights in some studies adalah tentang the problems in processing emotions in certain adolescents, resulting in a lot of interpersonal conflicts. And contohnya, ada one study dia tunjuk gambar emotional reaction, and they assess adult and then they assess adolescents, and they find out that there's a discrepancy in translating of emotion. And maknanya apa yang one image most adults perceive as fearful, adolescent view it as irritable, for example. So maksudnya somehow the area in the brain yang process empathy is not yet fully developed. Hence explain why sometimes parents mengadu anak dia macam tak kisah, anak dia tak faham saya ni stres, anak dia tak tahu saya ni susah, anak dia ni tak boleh nampak saya punya pengorbanan and what not. And so these are some of the issues yang related to development of adolescents. So next slide. One of the issues in the development adalah cognitive, and so kalau in children earlier on, the highlight was baca, menulis, mengira, hafal sifir and what not. Tapi in adolescent, dia punya cognitive demand dia is more complex, so dia dah start required to process reasoning skills, thinking skills, metacognition. Tahu tak metacognition ni apa? Siapa tahu metacognition ni apa? Siapa yang ada kat situ? Nabiah ke? Siapa yang awal-awal buat psychiatry? Fitriah ke? Siapa-siapa lah?
Awang Kaya.
Awang. Kalau tak dapat jawab, saya pulangkan balik distinction tu. Mana Awang? Saya tak nampak lah muka you all. Mana Awang?
Oh, dia join link satu lagi kot doktor.
Okay. Siapa je lah? Jas ke? Razman ke?
Is it macam we need to to think in other people's shoe?
Okay, kind of. So metacognition ni is thinking about the way you think. Okay. So basically macam ability untuk reflect back on ourselves lah. And macam contohnya lah dia pukul adik dia kan. Dan kita tanya, kenapa sampai macam tu sangat? Kenapa pukul adik tu? Dia tak boleh nak comprehend ataupun dia tak boleh nak compute, dia tak boleh nak cerita semula what's going through in his or her mind during that process. And so that's why Metacognition ni sometimes important bila kita nak buat psychotherapy and kita nak reflect, kita nak help dia untuk muhasabah, untuk dia berfikir, ubah cara fikir. So bila metacognition ni still tak develop, it's difficult untuk dia untuk kita highlight dia punya ability and apa yang dia boleh buat, apa yang dia tak boleh buat. And another important aspect is psychosocial development, and in which during adolescent macam saya sebut tadi, is the time of development, and so banyak benda work in progress. So they are developing their identity, they are developing their autonomy, they are developing the meaning behind intimacy, siapa yang dia boleh suka, siapa yang dia tak suka, kenapa orang suka dia, kenapa orang tak suka dia. And then sexuality is also another highlight and achievement. Ada one thing that we haven't explore here, tapi also common, especially sekarang ni ada isu tentang Instagram, TikTok dan sebagainya. Isu apa? Apa lagi ada isu yang important in adolescent? Whether dia tengok member-member dekat Instagram, dia tengok personality, dia tengok artis.
Peer recognition.
In society.
You're missing out of that.
Sorry?
Self-esteem.
Missing out.
Self-esteem.
Self-esteem tu kita dah sebut dalam identity.
Peer recognition.
Not quite. Especially ni yang perempuan kan, nak cantik, nak kurus, tak nak macam tu, tak nak macam ni. It's actually self-image issues. Okay, issues of body image, self-image pula. Issue of body image pun also another important highlight dalam adolescent lah. Okay, so carry on. So carry on with the case. So those are the things that you need to import. Those are the aspect yang you need to explore bila you deal with adolescent. So 13 years old tadi, presenting complaint yang saya sebut tadi. So what are your initial differential diagnosis? Najihah, apa important or your initial differential diagnosis that you can think of? So yang lain bersedia, I need 5. Okay? Lambat. Syamimi ke?
Adjustment disorder.
Adjustment disorder. Okay. Kenapa? Why do you think of adjustment disorder?
Because of he is 13 years old, so the patient might be attending the first time for the secondary school, and then the duration is for 3 months. So for the adjustment disorder must not exceed 6 months.
Okay. Now, apa symptoms adjustment disorder? Kan saya sebut bila when you want to justify diagnosis, you cannot justify it based on duration. Okay, you need to justify it based on symptoms. Apa symptoms of adjustment disorder?
Of the refusal to go to the school.
Okay.
Irritability.
Okay, now adjustment disorder ada 2 cluster of symptom. Number 1, depressive-like. So adjustment disorder with depressive symptom. Number 2, adjustment disorder with depressive symptom. And cuma in adolescent or in children, you have additional group which is behavioral problem. So you are correct. So we can consider adjustment disorder as one of differential diagnosis. Tapi nak diagnose adjustment disorder, kita kena ada apa? Apa benda wajib yang kena ada nak diagnose adjustment disorder?
New event.
We need to find out.
New environment.
So we need to find out what is he adjusting to. Okay. So symptoms kita dah ada, tapi dia punya reason for adjustment kita tak dapat lagi. Apa yang menyebabkan adjustment disorder cannot be an option? If
for example, if the adjustment is due to the school, but then they already been omitted from the school for the past 3 months, why the symptom doesn't really resolve?
Not quite, but you are correct in a sense that the symptoms tu must be reasonable untuk explain the stressor. Maksudnya contohnya, maknanya stressor tu mesti reasonable enough untuk produce such symptoms. Cuma what I'm saying is adalah antara syarat sah untuk diagnose adjustment disorder adalah patient tu must not fulfill any major diagnostic criteria of either mood disorder or anxiety disorder. Okay, and so adjustment disorder can be one of your probable diagnosis, tapi keep in mind at the moment patient to fulfill any specific diagnostic criteria for mood or adjustment disorder, you can no longer use adjustment disorder as your option of diagnosis. Okay, good. So that's one. Kita discuss something, kita dah revise tentang adjustment disorder. Second, Abil? Second differential diagnosis. Lepas ni Syakir bersedia, lepas tu Fatin.
Separation anxiety disorder.
Separation anxiety?
Anxiety disorder.
Anxiety disorder. It cannot be separation anxiety. Separation anxiety must start before 6 years old. Okay? 13 years old tak ada separation anxiety. So, you think anxiety disorder. Why anxiety disorder? Symptoms apa yang suggestive of anxiety?
Socially withdrawn.
Okay, so socially withdrawn tu relate dengan which anxiety symptom?
Social anxiety.
Social anxiety. Kau semua dah lupa dah psychiatry ni. Okay, remember as I mentioned, whenever you offer diagnosis dalam PMP, you must still relate back dengan number one diagnostic criteria. Okay, apa symptoms yang dia ada? And in what way does it relate to any specific diagnostic criteria in a specific diagnosis? So for example, if you say, I'm thinking of anxiety disorder, specifically social anxiety disorder. So my justification is patient has social withdrawal, which likely a presentation of social phobia in social anxiety. Irritability, for example, can also be symptoms of generalized anxiety disorder, for example. Refusal to go to school, it also can be a manifestation of social anxiety disorder in which patient was concerned about not being able to perform or scrutinized by others. So that's only jawapan yang acceptable. Okay, you have to have justification yang relevant with the presentation. Okay, third, Syakir?
Major depressive disorder.
Major depressive disorder. Okay, good. Why?
The patient previously had go to school. However, maybe patient had loss of interest, refused to go to school.
Okay, alright. So again, you relate back dengan symptoms yang you think relate to diagnosis yang you ada. Okay. So selain daripada anhedonia, ada one more symptoms yang relate to depression. Apa?
Low mood.
Bukan yang di present tu. So you kata refusal to go to school, social withdrawal tu can be anhedonia. Apa lagi symptoms yang relates to depression?
Irritability.
Irritability. Okay, so irritability is not diagnostic criteria for major depressive disorder in adult. Tapi in adolescent, irritability carry as one of mood symptom. Criteria A for depression. Okay, so remember this. We present at mana dia punya presentation can be slightly different. So basically they manifest as irritable, tapi the underlying symptom is actually depressed or low mood. Okay, faham eh? Okay, good. Fourth, Fatin? Lepas ni bersedia Faris, Nadia, Rahil, Wahana. Okay, Fatin? Differential? Ya, cepat, kita ada 19 slide lagi ni.
Doctor, I would like to suggest organic causes such as brain tumor.
Brain tumor. Okay, so how do you relate to that diagnosis?
Because the condition, the change of behavior that the patient can be also due to organic causes.
Okay.
Such as social withdrawal it can also be due to abnormalities in the brain such as tumor or infection.
Okay. Selain the symptoms, apa lagi benda lain yang pointing towards organicity?
It is gradually worsen, and for the period of 2 weeks to it becomes more worsen, gradual.
Yang tu any diagnosis can present sideways. Psychiatry pun boleh present grade 2 juga. Apa yang menyebabkan you tak fikir psychiatry ni? Kenapa? Mesti psychiatry ni. Tapi kita reason, maybe bukan psychiatry, maybe medical. Apa lagi hint? Apa lagi another possible clue?
Age, doctor.
Sorry? Yeah?
Age of the patient.
Correct. So age of the patient, 13 years old. So if you think along the line of psychiatric disorder, depression for example, anxiety disorder, would you normally see presentation at this age? Okay. So kalau any psychiatric presentation manifest in extreme age, sama ada too early or too late, you kena start fikir along the line of organic causes. Okay, correct. So it doesn't have to be brain tumor. It can be anything yang relate to neurological, brain lah kan. Okay, so one of the common causes is brain tumor. Can it be other causes? What are you thinking? You are thinking along the line of medical, tapi it is not brain tumor. What else could it be? Aiman? Siapa yang saya tak sebut nama nak sebut pun boleh. As long as ada gap 3 saat orang tu tak jawab, you boleh carry on.
Substance abuse.
Kejap. Saya punya soalan tadi adalah if you think along the line of medical causes, apart from brain tumor, what other medical causes yang boleh present in 13 years old, present in behavioral problem?
Temporal lobe epilepsy.
Okay, so you think along the line of epilepsy punya condition. Okay. Alright, lagi? Okay, kita cut short. So medical is one thing yang kita nak highlight. Okay. Now, fikir balik when you think along bila you fikir tentang in differential diagnosis, remember 4 group yang saya sebut tadi tu. Okay, jangan go randomly sangat. So you have to go back basic. So 4 group tadi tu, neurodevelopmental, emotional, behavioral, and then serious mental illness. Okay, now kita go satu-satu Could this be a presentation of neurodevelopmental? Boleh ke tak boleh?
Boleh.
Boleh. So what? What neurodevelopmental? Siapa yang kata boleh tadi tu?
It can be ADHD, ASD also possible. Because ADHD, I think because of maybe patient cannot really give attention to the school, that's why dia banyak benda nak buat. And then for ASD, maybe some issues with the social, so that's why the lack of peers, so make him to be social withdrawal. Another one, ID, I'm not sure. Different specific,
Okay.
but yeah.
Okay, now correct. ADHD, ASD, in fact ID also can manifest a rather late presentation depending on dekat mana dia punya demand tu sepas apa yang dia boleh buat. And contohnya in patient with autism, high functioning for example. So sekolah rendah dia boleh lagi function socially. Sebab apa? Sebab cikgu yang buatkan group, cikgu yang lainkan, cikgu yang masukkan rumah sukan, everything else. So dia boleh cope. Tapi bila dia masuk sekolah menengah, geng-geng dah start ada klik dan sebagainya, dia tak reti nak masuk macam mana, dia jadi anxious, dia jadi stress. So at the end dia refuse to go to school. Okay, so that can be explained by autism spectrum disorder punya manifestation. However, refusal basic self-care, so that doesn't really gel into neurodevelopmental disorder. Especially the problem only started for the last 3 months. Okay, so neurodevelopmental disorder ni problem dia must be pervasive, they must be persistent daripada childhood. So dia mungkin lebih manifest. You cannot have ID yang boleh mandi, boleh makan sendiri, tiba-tiba 13 tahun dah tak reti nak kencing, tak reti nak berak. So that cannot be intellectual disability. You have to think pasal something yang acquired. Okay, so that's neurodevelopmental disorder. So therefore, that's one of your differential diagnosis, one of the things that you need to consider dalam you punya options of diagnosis, dalam you punya further history taking. Under emotion, tadi kita dah cover anxiety, kita dah cover mood. Okay, good. Selain depression, you also need to be considering diagnosis of bipolar. And okay, irritability is there, so you need to be thinking along the line of bipolarity. Okay, now no one mentioned pasal behavioral. Okay, any suggestion on diagnosis under behavioral? Irritability, refuse to go to school, social withdrawal. Apa diagnosis yang you can consider? Apa?
PTSD.
ODD.
So ODD and conduct. Okay, so you have to think along the line of ODD and conduct. Okay, alright. So those are some of differential diagnosis. Okay, tadi ada somebody mention substance also good. So that's also another thing yang you need to be thinking. So bila substance, fikir, could this be symptoms of intoxication? Could this be symptoms of withdrawal? Or could this be symptoms of mood disorder due to substance, psychotic disorder due to substance? So if you carry all of those information, you can ada banyak differential diagnosis yang you need to be thinking of. So our next job apa? Now that we have lots of differential diagnosis in our mind, kita ada a lot of suspects. So our next job apa?
To investigate and narrow down.
So our next task is narrow down kita punya options. So kita start off with almost 10 suspects. So we need to narrow it down to only one possible suspects. So what are the important information you need to diagnose? Of course, you need to go back to the principle of the diagnosis. So if you think ODD, apa basic information you need for ODD? If you think along the line of ADHD, apa basic information you need to look for in ADHD? So what we look for? Mesti number one, diagnostic criteria. Okay. Number two, baru supporting features. So in exam, bila jawab soalan yang macam ni, jawab balik. Jawab semula dalam bentuk I want to look for symptoms of this, symptom of that, for that duration. Because dah 3-4 posting bila jawab PMP, saya still lagi dapat jawapan family history, personal history, pre-morbid personality. You will not get marks for that because that's general information. We want specific answer because the question is specific, important information in order for you to come up with the final diagnosis. Okay, next slide. During the initial assessment, patient was not forthcoming. Patient responded minimally with questions. Jawab tanya sepatah, jawab sepatah, tanya sepatah, jawab sepatah. Mata tak tengok, poor eye contact. You're not really getting much information. So how would you address the issue? Macam mana you nak tackle adolescent yang tak jawab sangat ni? Adolescent yang klik-klik ni. Macam mana? So we need to hurry up. Jawab laju-laju sikit. So how would you tackle?
Maybe we can find out the point of interest, like common interest, and then we have to bear in mind that kita mungkin ada multiple visits to complete our history. Lagi tak sure lagi. Orang lain?
Okay. So number one, kita kena build rapport. Okay. So even though you have differential diagnosis that you have in mind, tapi remember, to the children or to the patients, that's not really matter. I'm not really here to bother about your differential diagnosis. I'm here to understand and make sense. Why am I here? Why suddenly I have to be in the room with some strangers asking me random question, baju bunga-bunga benda ala semua ni, apa dia nak tahu ni? Okay, so you need to establish rapport. So macam mana nak establish rapport? So tadi, siapa tadi tu Wana tadi your friend suggested get a common interest. Good. Okay, so tanya apa yang dia minat, apa yang dia suka, just commenting on things that you can start the conversation. Lagi macam lagi nak build rapport?
Communicate, show that you are communicating with the mother, communicating with the mother well, so that it creates a sense of so that the patient macam more being welcome.
Okay, all right. So always remember, if you put your shoes on the children or on the patient, so most of them are anxious. Kan macam situation yang saya sebut tadi lah, strangers, you don't know what to do, you don't know what to expect. Some of them are tricked to get to clinic. Okay, so just trust me, most of my patients yang adolescent ni, they're not aware pun they are coming to see a psychiatrist. Mak dia kata datang nak cek telinga lah, datang nak cek hidung lah, datang nak cek gigi lah, datang tengok jumpa Dr. Nizam. So some of them really anxious. So what I did normally adalah I explain to them in a very basic term. Tempat ni apa? Why are people here? Who am I? Kenapa kita buat ni? Kenapa kita duduk? What's the reason they are here? And sometimes I normalize as well. Okay, so we normalize them. I say, it's okay if you feel anxious. Kalau saya pun saya takut juga. If I am in your position, I will be anxious as well. I will be worried as well to answer. But that's normal. Cuma you need to know that you are safe. Okay, so ensure their safety. Okay, another point is you also need to remember that sometimes rapport tu cannot be built in one session. So you may need to see them a couple of times. So sometimes I just spend times try to engage with them. If I cannot, I don't push. So you tak duduk tolonglah cakap dengan saya ada banyak lagi patient ni, tolonglah cakap. You cannot do that. And sometimes what you do is you call up the mother, you say, sorry, I've tried, I just cannot. So maybe not today, we may need to find other time. So you not push them. Right. So another important things as well is issues of confidentiality. Because sometimes that they are concerned why they're not talking. So you need to highlight. Semua yang saya sebut ni sebenarnya jawapan you'll remember je. So explain to them about confidentiality. Another thing adalah the way we get information. How do we get information? So tanya tak jawab. How else can we get information?
Boleh minta patient tulis.
Okay, so sometimes we can use non-verbal. Okay, so sometimes we can use non-verbal. So, for example, you can just comment, nampak sedih, nampak marah, do you want to talk about that? Or you can use non-verbal macam writing. You give them dust, you give them papers, you give them scribble, you give them colours for them to colour. And then, so from that you can start have some idea apa yang ada dalam dia punya fikiran dia. Apa lagi another important source of information?
Ask other person.
Okay, so you can also go get information from other patients. Cumanya with adolescents apa issue dia? Apa yang you need to get? You need to get their permission. Okay, so you need to let them know. Okay, I know you don't really want to tell me, but it's important for me to understand why you're here. If you don't want to tell me, if it's okay if I get the information from your mother, do you allow me to get information from your mother? So kita bagi dia. Kalau dia tak bagi, and sometimes you just emphasize, I know you don't feel comfortable, but I cannot help you unless I get some information. If it's okay, I want to see your mother, but I'll find out things that but I will check with you whatever information that I get from your mother. Okay, because some of the adolescents they're paranoid. They're worried that their mother or their father will talk back about them behind them and not telling the truth. So what we're trying to portray to them adalah we are on their side. Okay, so these are important skills yang kita ada in order untuk kita get information from the patient. Okay, so from yes.
Sorry, I just curious. What happened if the adolescent refuse treatment? I mean, they don't want to involve with this psychiatric thing.
Okay, now for adolescent sebenarnya treatment ni dia sama konsep dia macam treatment in medical and surgical. So they are still incapable of giving independent consent. Okay, so their consent must be dependent on dia punya parents. Okay, so maksudnya whatever it is, dia kena go back to parents dia. And contohnya dia tak nak, tapi parents kata kena, so kita go by parents. And cumanya of course it's not black and white lah. And contohnya macam budak tu dia kata tak nak makan ubat, tapi parents dia kata parents dia nak bagi makan ubat. So what we can emphasize to the parents adalah now you have the rights to decide management for your child. However, we need to do it in a way that does not cause harm. And maksudnya kita tak boleh, walaupun anak tak nak, kita tak boleh sembunyi-sembunyi masuk dalam makanan. Kita tak boleh masa dia tidur, kita tutup hidung dia, kita masukkan makanan. It's a diplomacy yang kita kena emphasize on. Okay, unless it's life threatening lah. Okay, contohnya anak tu suicidal, anak tu tak ada masuk ward, tapi parents agree untuk masuk ward, yet kita still go by parents. Okay, tapi untuk benda-benda yang macam nak attend psikoterapi ke tak, nak jumpa doktor lagi ke tak next week, semua tu it's open to negotiation. Macam mana kalau parents go against the needs of the child? Contohnya child tu depressed, child tu nak makan ubat tapi parents tak kasih. Macam mana? 13 years old, depressed. We think patients need medication, patient agree, mother tak nak. Macam mana kita nak tackle?
I think it's the same as the child. We can take over the role. Where saya lupa nak kena refer pada siapa. But we first start with advice, and then if the parents insisted against that, so I'm not sure what kind of department or yang kita refer for us to take over the decision to give treatment to that adolescent.
Okay, department pula nak hantar ke department apa? Urology.
No, I mean it's not that kind
Forensic.
of service. I'm not sure what kind of
Service. Oh, okay. Yang lain? Ada any opinion? Faham tak soalan saya? Anak nak makan ubat, parents tak kasih makan ubat.
I think first we need to know why. We need to explore with the parents. Why does the parent don't want the child to take the medication?
Parents dia kata tak nak, nanti anak saya bergantung ubat, nanti anak saya sakit buah pinggang.
And then we give them reassurance lah. Macam we address the problem.
Okay, so dia kata saya faham semua explanation doktor. Tapi as a father, as a mother, saya punya decision ialah saya tak nak anak saya makan ubat.
Okay.
Can we consider it as a negligence?
Okay, so dia go back to principle of the management. Okay, sama juga macam medical, sama juga macam surgical. Is your treatment that you want to offer is life threatening atau tidak? So kalau is life threatening, sebenarnya kita boleh disregard parents punya decision. Tapi if it is not life threatening, sebenarnya authority still go back to parents. All we can do adalah kita just document. Okay, ni medical legal lah. Maknanya kita just document, we have explained, we have blah 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 blah. So parents tidak nak, parents signs. So it goes back to risk and benefit. Contoh, anak tu mildly depressed, sikit-sikit tak boleh tidur, lepas tu macam ada rasa rasa putus asa macam tu, and we think the benefit of medication tu has benefit. And tapi it is not life threatening. Maksudnya it's not that if you don't take the medication, patient will die. Unless in the situation where kat mana yang life threatening. Contohnya patient tu psychotic, patient tu suicidal, patient tu homicidal. So in this case, you kena override parents punya maknanya masa ni, maknanya it's a life threatening, maknanya you are bound untuk manage patients tu punya situation as an emergency. Okay, cumanya in psychiatry ni tak ada yang ultimate emergency. Okay, so treatment kita ni basically untuk reduce symptoms, they are not life threatening. Unless macam admission macam tu, yes. And tapi antidepressant sebenarnya tak. And because if you go to court, people akan kata is antidepressant the only answer to this management? Tak juga. So some may think we can use psychotherapy and we can use other forms of treatment. Okay, so therefore it really depends on dia punya treatment yang kita offer. And kita juga tak nak go against the parents. Kita kata tak nak, tak boleh. Encik ni ibu bapa yang tak berjawab. Kenapa juga? Nak ambil prescription slip ni, pergi kat pharmacy. Do you think they will take it? Now of course they won't take it. So there's no point arguing. And so sometimes what I do as a patient, what I do as a psychiatrist adalah I explain to them, and then if they still insist that they don't want, and I said to them, it's okay, it's your right, but we need to give ultimatum. And maksudnya we need to give some boundaries. For example, I said we try with psychotherapy, we try with occupational therapy input for 1 or 2 months. If at any point your child's condition deteriorated, or at any point he or she becomes suicidal, then I think it's mandatory for us to treat him with antidepressant. Okay, so that's ultimatum tu is important untuk dia faham the seriousness of dia punya decision. And of course later on dia tak nak datang ke, it's up to them. apa yang important is kita punya documentation and what we do. And always remember, ethical in psychiatry ni ada one clause nama dia autonomy. That means patient has autonomy even though the autonomy is not absolute. Tapi autonomy tu ada, and we not the god for the patients. Okay, we cannot decide everything for them. Alright, so further history, patient give okay, so bila kita tanya yes and no semua tu, dia jawab lah sikit-sikit. We get history that patient has been feeling depressed for the last 4 to 5 months for no apparent reason. He denied any problem related to school, family or friends. He was not interested with his usual hobbies of playing football and computer games. His trouble sleeping at night and lost appetite. He admitted of feeling hopeless for future with fleeting thoughts of suicidal. He denied any specific plan or attempt. He admitted of feeling anxious about school but denied persistent symptoms of anxiety. He denied any psychotic symptoms or manic symptoms. Okay, carry boleh saya nak move to next slide. Okay, so next slide. He insisted that you did not inform the mother regarding the suicide ideation. So how would you respond to his request? So macam mana you respond to his request? Dengar sikit jawapan dia. Aklan? Jawab macam mana Aklan? Faris ke? Siapa-siapa lah. Siapa yang ada mic cepat?
Regarding how do we respond to this request, that we need to explain, as what Dr. explained just now, we need to explain the seriousness of the problem, and the issue of consent is actually on behalf of the mother and father, and if they still insist on, and we can overrule based on the life-threatening situation. So for this case, we should not for me, we should explain the importance of telling the parents of this.
Kalau patient kata tadi, doktor kata confidential, semua benda confidential.
Not sure, doktor.
Tadi nak biar repo kata confidential sangat. You pun dalam klinik kan begitu confidential. Tak cerita kat luar. Macam mana? Nak beritahu mak pula. Macam mana?
Doctor,
yes?
I'm not sure. This is what I observed from one case of adolescent. First, assess the severity of the suicidal ideation. If it is macam like a really serious and severe, macam kena bagi tahu dia, although it is confidential, but we actually care for you, macam about this is your life, so kena bagi tahu je parents for them to take precaution. But in the case yang hari tu, case tu, that child is not. We're not really sure whether this is true suicidal or not. What the doctors did is that they inform the parents not the suicide intent, more like the child need macam really vigilant monitoring. So they ask them to watch the child frequently. Not sure whether this is appropriate or not.
Okay, betul, correct. So it really depends on the seriousness of the symptoms that patient reported. So you need a clinical judgment. Contohnya kalau patient begitu, kadang-kadang adalah terlintas, so bestnya kalau mati, tapi tak ada buat apa-apa, then it may not be as serious as compared to patient beritahu, oh, saya ada Google kat doktor cara nak ikat tali, cara nak gantung diri, lepas tu saya tahulah pukul berapa yang mak saya tak ada kat rumah, so that is more serious. So therefore you emphasize to the patients yang yes, correct, there is a confidentiality, tapi confidentiality tu has limits. Okay, maksudnya there are exceptions. And so exception dia apa? Exception dia ada 3. 1, 2, 3, 4. Exception dia nombor 1 is suicidal, nombor 2 adalah homicidal, nombor 3 risk to nombor 3 adalah risk of others to patients. And suicidal lah, homicidal ni dia ada ideation nak buat apa-apa. Yang ketiga, risk to others. Contohnya dia bagi tahu ayah saya malam-malam ketuk pintu saya, masuk bilik saya. And so even though anak kata jangan bagi tahu, you're not bound to confidentiality in this case. You have to report. Okay? But you have to be careful as well. You have to balance it out. Okay? Kalau the intensity tu is not that great, and you want to keep patients punya repo so that you can treat patient better, then you may want to hold to that report. Tapi kalau memang patient tu ada serious intention nak buat balik ni juga, then you tak perlu tunggu repo-repo lah, you just terus bagi tahu sahajalah. In fact, patient may need admission. Okay, so that kind of actions. So these are the things yang you need to be thinking seperti seorang manusia, even though there's a rules and regulation. So as a clinician, you kena ada human mind as well, not just textbook mind sahaja. You need to have some ideas macam mana nak put in context of rules and regulation yang ada. Okay, so next kita go laju-laju. His mother also denied any specific trigger for this episode. Okay, so that goes away your adjustment disorder punya diagnosis. She reported consistent history of depressive mood in her child. Maksudnya mak pun nampak benda yang sama, nampak macam dia tak happy, nampak macam dia lost interest. He was described as a very shy boy, quiet and obedient. He has few friends, mostly shared with his younger brother. So mak tak realize or tak notice any neurodevelopmental problem. However, his parents divorced when he was 11 years old. Mother denied any emotional issues following the separation. No suspicion of substance-related issues, and no current or underlying medical problem that we know of. Okay, so mental state revealed thin Malay boy. So next slide, mental state revealed thin Malay boy in casual attire. There was no sign of neglect. He was sitting with apprehensive look, fidgety, looking down most of the time, with prominent eye. Mata dia macam tersembus sikit, but no other ophthalmic abnormality. Superficially cooperative, no hostility, no abnormal movement. Depressed, affects appropriate, no lability, no perceptual disturbance. There was presence of depressive thought content. However, no delusion, no formal thought disorder. He has poor concentration, poor insight, poor judgment. Vital sign, neurological examination are grossly normal. Okay, so you boleh capture information yang saya share ni. Okay, so next, what is your working diagnosis? Okay, so siapa nak bagi working diagnosis at this stage? Siapa nak bagi working diagnosis? Razman? Ayu ke? Ni grup first saya ni ke? Kau balik dah semua pergi semayang. Dengar tak ni?
Ada. Ada.
So diagnosis?
Saya pass kepada Ayu.
Ayu? Main pas-pas pula dia.
Itulah doktor. MDD doktor.
MDD, okay, why?
Because from the history itself, patient have suicidal thoughts. And then the MSC also showing more towards depressive punya signs.
Tengok tu dia dah melompat. Saya kata kan, whenever we ask why do you think it's that diagnosis, jawapan dia mesti back to the diagnostic criteria. And so you mesti jawab patient fulfill ke tak fulfill MDD?
Fulfill doktor.
So jawablah fulfill. Patient fulfill major depressive disorders punya kriteria. Patient ada low mood, anhedonia, associated symptom more than 2 weeks. Okay, and cuma yang apa points against MDD?
Yang age doktor.
Okay, yang age lagi? So it's probably fairly young untuk get depression at 13. It's not impossible, tapi that makes you wonder, betul ke depression ni? Lagi? Apa yang kita belum exclude? Apa yang kita belum entirely exclude?
Bipolar and depressive.
Organic causes.
Okay. So having said, so knowing that he has no current and underlying medical problem is not really an exclusion of medical causes. Remember, even normal vital signs, a normal neurological examination also not entirely exclude medical causes. So we still need to have back in our mind some medical causes. Okay, alright. Another things yang pointing towards possibility of not depression adalah absence of trigger, and which is also something yang rather unusual for somebody yang ada depression. So normally in depression ni kita jumpa at later stage, 20 to 30 years old, 30 to 40 years old, depending on the study, and normally kita akan jumpa life events. And so kalau tak ada life event, in the absence of life events ni jarang kita jumpa orang depression. And unless it's bipolar depression. So that's also another possibility yang kita kena consider. Alright. So how would you manage? What would you do? So cut short, so kita of course we need to do a biopsychosocial investigation. So biologically we need to look at all the important diagnostic criteria yang kita tak, yang differential diagnosis yang kita haven't covered. Now, blood apa semua tu of course you do. Mata dia tersembul tadi tu, apa yang you thinking of?
Thyroid, doktor.
Thyroid. So kita buatlah semua, kita buat semua blood test. Would you consider CT brain in this case?
Yes.
Yes, doctor.
Because the first episode of that the patient have.
Okay. Generally speaking, the only points untuk you push for CT brain adalah dia punya presentation at 13 years old. Other than that, sebenarnya you don't really have anything untuk bagi tahu, untuk justify why you need to do CT brain. Okay, of course bila you nak buat CT brain, you kena menghadap radiologist kan, and so you kena justify why this patient needs my service. Okay, and so other than 13 years old, you can't really, because patient tak ada physical symptoms, patient tak ada physical findings. Okay, so maybe you get eventually kalau you baik, buat saya radiologist dan kita boleh kau team, and tapi generally you might not get urgent one lah, you may get it somewhere down the track lah. Okay, alright. And then psychological, so of course you need to look at psychological assessment, you need to look at developmental punya assessment if needs be, you need to look at patients punya social situation. In certain cases maybe you want to do home visit if you think macam ada benda yang tak kena, I don't get enough of information based on this appointment, patients may need additional home visit untuk dapat more information. So all are investigations and relevant. Okay, so apa important questions yang we haven't answered? Okay, so I agree with you. This is major depressive disorder. So in fact, I treated the case as major depressive disorder initially. So apa biggest question that we haven't answered?
The stress.
Why now?
Why? Betul. The why. Okay? Because unless we get the why, we will not be able to treat. Betul tak? Because our treatment for depression basically symptomatic relief. And kita bagi antidepressant nak bagi mood dia improve, tidur dia okay. Tapi selagi kita tak jumpa punca dia, patient akan continue to come back to depressive states. And when our treatment is taken away. So kita nak get to the bottom of the problem so that kita tahu apa what we dealing with. Okay? So in one of the sessions, sebab patient ni tak nak banyak, tak nak buat banyak benda, so I get patient to draw. So next slide, Adin. So next slide, can you all see the picture? Nampak tak? Yes. Okay, so this is a replication of patient's punya drawing. It wasn't really a patient's punya drawing. So saya suruh anak saya lukis mula. So it's a replication of patient's punya drawing. So I asked him to draw family. Okay. So this is what he drew. So yang tinggi tu dia, and then dia ada dua adik, and then there was a gap, and then there's another person, and that person is dia punya father. Okay. So as I mentioned earlier, patients ni came from a divorced parents. Dia duduk with the mother. Father came macam 2 weekly macam tu, sebab father lives in somewhere in interstate. Okay, so apa yang tak kena dengan gambar ni?
No mother.
Okay, so very obvious mother wasn't there. So all this while mother was the one that brought patient to clinics, but mother wasn't there. So I asked patient, kenapa tak lukis gambar mak? Kenapa gambar mak tak ada? Kenapa agak-agak jawapan dia?
Mak dia tak percayakan dia.
Saya dah cerita ni.
Dah saya.
Oh, saya dah cerita masa year 4. Okay. So, he was upset. Betul kan saya cerita masa year 4 dulu kan?
Betul.
Yes.
Okay, so he was upset with his mother. Okay, the reason was because mother dia tak percaya dia. So cut story short, there was a reported incident that father did something to this child. Okay, but until now we were still not able untuk either make a report or bring it up further, and because lack of details, and so at the moment a lot of it tu macam hearsay from what mother said. Patient sendiri tak pernah mention anything yang specific. Mother pun denied observing or witnessing it, and so kita tak boleh proceed. But what we know, something bad happened in the life of this child in relation to apa yang dia cerita. Okay, so next slide. Patient was started on fluoxetine 20 mg and zolpidem 5 mg on night. We gave him supportive psychotherapy and behavioral modification. And so maksudnya behavioral modification ni maknanya kita encourage dia bila dia pergi sekolah tu, suruh mak dia bagi reward, prompt dia, schedule dia punya behavior. So that's behavioral modification. Supportive psychotherapy ni specifically kita allow dia ventilate dia punya problem and whatnot, and which we didn't get much anyway. And tapi kita continue dia on fluoxetine, which is fluoxetine ni apa? Fluoxetine ni apa? SSRI, okay, pandai. Siapa yang ingat lagi tu SSRI. In fact, fluoxetine is the only SSRI yang approved for below 16 years old. Okay, yang lain semua off-label used. Okay, and noted that there was improvement in his mood around 3 months following intervention. He was able to go back to school, however still reported to be slow in his movement and social activities. Still tak nak keluar petang-petang main bola, banyaknya duduk kat rumah tapi dah boleh pergi sekolah. Claim that he was able to do some homework, bila dia tak boleh, dia serabut sikit, dia tak pergi, tapi otherwise overall dia punya mood tu improved. Okay, next slide. So since then unfortunately patient defaulted treatment and follow up as they felt that patient is now better. Okay, so as usual, they didn't see any reason why they need to keep taking medication if patients already improve. So okay ke tak okay? Okay ke tak okay? How long do you need to be on treatment?
6 to 9.
6 to 8 months. Okay, 6 to 9 months lah, lebih kurang, in order untuk prevent future relapse. Okay, so not surprisingly, what happened? Next slide. 3 months later, patient represented to clinic with presenting complaints of slowness in movement, poor self-care, poor social interaction, and school refusal. Patient occasionally became irritable when insisted to prepare to go to school every morning. So what happened is, dia jadi slow, dia jadi macam duduk saja, mandi pun tak nak, makan pun payah, tak nak bercakap dengan orang, tak nak keluar. So bila mak dia bising, pergilah sekolah, buat apa nak jadi apa, tak pergi sekolah apa semua tu. So bila mak dia tarik dia pergi ke bilik air semua tu, dia akan tolak tangan dia, tepis tangan dia sampai mak dia kena lah. So that's what parents describe as irritability. So what's your comment on his current presentation? What happened now?
I think it's like a relapse, but the symptoms are more severe compared to the first initial presentation.
Okay, so agree. So it looks like relapse. Okay, in fact, I at that stage view it as relapse as well. Cumanya looking back, if you look at the symptoms profile this time, apa yang beza?
The slowness in movement was not there during the first.
Okay. So the highlights of this current presentation is not so much related to emotion. Okay, so it's more of a psychomotor retardation rather than depressed mode, hopelessness, worthlessness. In fact, it wasn't there. Okay, so bila saya tanya, rasa sedih ke, rasa putus asa, rasa bersalah, dia denied. Okay, so this time there was no subjective depressive feeling. Tapi given that previously he responded to medication and the presentation this time following recent onset of cessation of treatment, so kita treat it as relapse of depression. So apa kita buat? What do we do?
Start back the medication.
So kita start back the medication lah. Okay, so next slide, he was started back on fluoxetine 20 mg on night and claimed compliant to the treatment. So mak dia kata, saya dah bagi dah ubat. So kali ni saya tak tipu, doktor, saya bagi ubat. However, for the next 2 months, there has been minimal improvement in the symptoms. Okay, so maknanya despite kita bagi the fluoxetine again, this time he was not improving the way we wanted him to be. Okay, so unlike last time where he responded pretty much within the same duration as well. Again, another concern is he continued to have slowness in his movement and indifference to surrounding. Mak dia kata macam blank macam tu. Okay, the words the mother said, and very poor social interaction. Dah jadi tak banyak cakap. Okay, so how would you manage patient at this stage?
Optimize status.
Firstly, I explore whether the patient comply to the medication or not.
Okay, good. So mak dia kata comply.
Okay, if comply, you can consider increase the dosage up to the maximum allowed.
So fluoxetine ni kind of optimum dah lah, 20 mg ni for adolescents. You can go 30, you can go 40, you can go 60, but according to literature, dia punya added value isn't that much. In fact, dia tak improving. So you're not optimizing, you basically patient's not improving with fluoxetine.
And then if not improve with increasing of dosage, can consider adjunct with benzodiazepine, or change the different type of medication.
Okay, so remember your options adalah switch, add, optimize, kan? You ada 3 option. Okay, so you can optimize, you can either switch or add. Problem with adding medication adalah compliance. So if that's not an option, then you're left with another one, which is switch. Okay, so you can switch it to other medication. So agree, so you switch. Cumanya, thinking back, sebenarnya what you also need to do, other than optimizing the medication, whenever your patient is not improving with your treatment, apa benda pertama yang you kena buat?
Reconsider diagnosis.
Okay, good. Very, very, very well. So what you need to do is stop and think again. And in fact, this is probably one of the mistakes that I did when managing this case, and in which we did not re-challenge kita punya theory that this actually we are dealing with depression. So you should stop and think again, what am I missing? Are we treating the right thing? And are we shooting the right target? Okay, so anyhow, what we did, next slide, is we changed patients to venlafaxine. Venlafaxine ni apa? SNRI. We treated him up to 150 milligram on night, again with no improvement. In fact, problem worsened since 3 months ago, so roughly around bulan puasa macam tu this year, where his condition deteriorated. Family reported symptoms of blank stares, immobility for hours, and passing urine in his pants. Maksudnya, dia duduk saja sampai tak pergi bilik air, kencing dia atas katil macam tu. Okay, but family denies any hallucinatory or other disorganized behavior. 2 weeks prior to presentation, his oral intake further deteriorated sampai tak makan dan tak minum. Okay, now apa yang you notice different this time? Yang when you think about dia punya presentation,
macam dah ada symptom of suggesting psychosis.
Okay, good. So dia tak nampak, it doesn't sound and doesn't looks like depression anymore. So if you think about psychosis, what symptoms yang you nak relate dengan psychosis?
First kali mungkin presentation earlier adalah prodromal punya prodromal feature of psychosis, and then for current presentation dia ada blank staring, lepas tu immobility for hours, and also passing urine in his pants, which is grossly abnormal.
So blank stares, immobility for hours tu apa?
Catatonia.
Catatonia. Oh, okay, alright. So now it looks like it fit characteristics or features of psychotic related disorder. Okay, that's one possibility. But mind you, psychosis is a symptoms, it's not diagnosis. So whenever patients presented with symptoms suggestive of psychosis, apa yang kita kena fikir?
Hallucination and delusion.
Bukan, maksudnya diagnosis.
Schizophrenia.
Schizophrenia,
abuse.
Okay, lagi?
Schizophrenia, substance abuse, MDD with psychosis.
Lagi?
Bipolar.
Betul, lagi? Betul, lagi? Ada
bipolar with psychosis.
Okay, betul. Ada satu saya tak dengar lagi.
Epilepsy with condition.
Okay, kalau you ingat saya punya bulat-bulat petak, and so you have to remember everything yang duduk dalam tu can be the options of diagnosis. So you have functional hallucination, functional psychosis, macam schizoaffective, schizophreniform, brief psychotic disorder, delusion disorder. You have yang overlap with mood, MDD with psychosis, bipolar with psychosis, schizoaffective. And then on the outside of the circle, you have options of apa?
Medical
and substance. Okay, so bila patient presented macam psychosis, you have to think that all of those are still possibilities. Okay, so now it looks like we're dealing with a psychotic presentation, maybe catatonic, but what is the reason behind that? Okay, now what would be your management at this stage?
Admit patient. Consider.
Kenapa now? Why now do we consider admission? Patient tak suicidal pun.
Because of the reason of oral intake deterioration and mungkin to help us in diagnosing. Yeah.
Okay, good. Very good. Okay, so one is patients punya risk. Second is facilitation of treatment. Okay, so these dua benda ni akan bantu kita. These dua benda ni buat kita rasa admission is warranted. Okay. Okay, now saya sebenarnya reluctant. Saya ada video of him being catatonic, tapi sebab you all letak ni dalam you all punya YouTube kan, so saya tak jadilah bagi. So some of your friends sebenarnya ada video patients ni di ward, saya ada share. Saya rasa my last group last posting ada, tapi this is patient's photo. Yang baju kemeja seluar hitam tu your lecturer, yang tu HO, yang tu kawan you all. Saya tak ingat siapa yang join saya masa tu. Yang baju hijau tu patients that we are discussing at the moment. So what do you see? Siapa yang boleh report? What do you observe?
First is the posture, Doctor. I'm not sure whether you asked him to do anything. But
kejap. Siapa yang ada situ hari tu? Tu gambar siapa tu? Yang kiri tu siapa? Siapa? Afaf. Okay, Afaf. Report to us. What did you see? What did we do and what do we see? Ada seorang lagi. Yang lelaki siapa tak ingat saya?
Aira Sofia.
Aira. Yang lelaki tu siapa?
Juma.
Faris. Betul. Faris lagi satu. Okay. What did you see? You nak share with your friend?
So, during the presentation, patient appears to be stupor. There is no psychomotor activity. And then we try to raise the patient hands passively. And then the hand is fixed with that posture. So, indicating that this patient has a posturing.
Okay. Patient sendiri macam mana? Expression. Patient sendiri. Patient tu macam mana? Expression, dia punya communication, macam mana?
So patient is not responding, not talking anything to questions being asked, and then patient sitting in a stooping posture, downward gazing. However, there is no depressive feature macam vertical furrowing of the eyebrows. of the
So bila
process.
kita ask patient to do anything, contohnya from bed to the garden, apa yang kita experience?
Okay, patient has negativism, and then patient resists for being passively moved.
Okay, so patient resist. Okay, so you all dengar your friends mention tadi tu. So ada resistance, ada mutisms, ada stuporing. So patient is actually ada posturing as well. And then apa yang kita nampak sekarang ni adalah this is what we call a waxy flexibility. Yeah. Okay, so patient is actually can be molded. Okay, you shape, angkat tangan macam ni, gerakkan macam ni, so they maintain that. And sebenarnya it's not as bad as waxy flexibility. Dia macam posturing ke arah waxy flexibility lah. Dia same spectrum lah. Kalau you kata posturing pun dah betul dah. Posturing tu is actually maintaining odd postures for a long time. So which is also a symptoms of catatonia. Selain yang ada dekat situ, orang lain yang observe the picture, what else can you notice? Saya nak tengok you all ni observant ke tak. Ada satu benda lagi yang you all sepatutnya notice. Apa lagi yang you all perasan?
Luar dia
in the
basah.
picture? Okay, good. So patients are actually passing urine bila kita bila dekat tengah-tengah laman tu lah, tengah-tengah laman tu. Okay. Patients currently 14 years old. So we are talking about 14 years old. Kita bukan cakap pasal chronic schizophrenia patient, we're talking about 14 years old presented in such way. Now, bila you look back, Adin satu slide, back one slide. If you look at the set of symptoms other than psychosis, can you think of anything else yang boleh relate to that relate to that presentation as well that we haven't mentioned? Blank stares, immobility, passing urine.
Temporal lobe.
Absent seizure.
Okay, good. Okay. So another thing yang kita kena also consider adalah possibility of seizure. And cumanya passing urine in seizure ni selalunya jadi masa bila?
Generalized tonic plan.
Masa GTC. So basically masa GTC what happen is dia punya autonomic nervous system to shut down. And cuma this patient dia bukan GTC, dia passing urine ni almost macam disorganized punya behavior lah. And however the blank stares, immobility for hours tu kita kena consider pasal possibility of seizure related disorder as well lah. Okay. Historically there has never been GTC or febrile fit in his life lah. Okay, next slide. Adin, 24. Slide 24. Okay, so during admission patient reported sikit lagi kita nak habis. During admission, patient reported to have catatonic symptoms, mutism, negativism and stuporing. He refused to eat. Direct question revealed minimal information except that on one occasion he admitted of hearing voices for a year duration. So yang ni pun, that's it. That's the only thing that I had. Ada dengar suara tak? Ada. Dah berapa lama? Setahun. So itu sahaja. So I did not get what is it, second person, third person, persistent tak persistent, and ever since I did not get similar information. Okay, so it was macam window of opportunity. Later dia tak pernah admitted of the same thing. So what's your working diagnosis now?
Can we say schizophreniform?
Okay, schizophreniform ni maksudnya you referring berapa bulan dah ni?
Dia dah more than 1 month tapi dia tak achieve 6 months.
Okay, so you're thinking pasal schizophreniform. Alright, lagi? Ada yang ada. Okay, so sekali lah tu schizophreniform tu ada beradik lah ya. Kita dapat makan ekstra lah.
Doktor, kalau macam catatonia specifier for MDD, Doktor?
Okay, so do not forget that MDD with psychosis ni is still an option of diagnosis. Number one, he has depression in the past. Number two, having psychosis now does not rule out that it's actually MDD with psychosis. And it is possible that the psychosis tu overpowering the depressive symptoms sampai kita tak dapat the depressive symptoms lah. Dia macam orang yang manic and psychotic. Tapi psychotic dia very prominent, kita rasa dia schizophrenia. But one psychotic dia tak ada, baru kita nampak rupanya ada elevated, ada increased co-directed activity and whatnot. So MDD with psychosis is one option, schizophrenia is one option. Lagi? Have we actually ruled out medical related causes?
No.
Okay, so we have not really entirely exclude medical causes. Okay, however, what we do now adalah we are dealing with catatonia. So we need to work with the symptoms first. I mean, we cannot wait until we have a final diagnosis. We kena manage. Anyhow, we kena manage. So kita punya CPR now adalah kita kena get him to eat and drink so that dia tak fall into dehydration and acute kidney injury and death. Okay, so baseline blood was normal. We did CT brain given that the seriousness of the presentation. However, CT brain was normal. Blood, in fact, was normal. It was started on lorazepam 1BD. Sebab apa kita bagi lorazepam?
Rapid onset.
Lorazepam ni kita bagi sebab catatonic symptom. Okay, so one of the indication for lorazepam adalah one of the treatment for catatonia adalah lorazepam. So kita bagi lorazepam. Olanzapine ni apa?
Antipsychotic.
Antipsychotic. Baik ingat lagi. So antipsychotic and mirtazapine. Mirtazapine ni apa?
NASA.
Okay, so antidepressant. Good. So basically we are treating him with everything. So kita bagi antipsychotic because he's psychotic, kita bagi antidepressant because he's depressed. So basically we want to get rid of the symptom as quick as possible. Do not want him to be deteriorated further so that we can get to the underlying of the problem. And then so initially with the olanzapine and kita bagi dia IVT with prompting and everything, dia start boleh makan sikit-sikit. Okay, we push food, fluids and everything, dia boleh makan. Tapi symptoms of catatonia tu is still there. Mutism, stuporing is still there. So what happened is kita switch the antipsychotic to aripiprazole and then kita start ECT. Apa indication for ECT at this stage?
Catatonia.
Okay, one is catatonia. Dua?
Refractory to medical treatment.
Good. So poor response to medical treatment. So we treat him with ECT. Okay. So he had total of 12 ECT session with minimal improvement. And however, there was fluctuation in the improvement. Maksudnya, lepas third ECT, fourth ECT, dia macam okay sikit. And then after sixth ECT, dia deteriorated balik. So there's a fluctuation of symptoms. And he still require assistance for oral. So still not really free of dia punya catatonic symptoms lah. Still ada psychomotor retardation despite optimization of treatment. Okay, so kita consulted neuromedical. In fact, medical have seen the case at the beginning of the admission, but they don't think that there's any medical causes that they need to investigate further. So, and then later because that they improve poorly with ACT, kita consult them again. So what happened is this time they agreed to do EEG, and recent ECG shows there's a focal but bitemporal cortical dysfunction with bitemporal epileptiform discharges. So maksudnya apa?
Temporal
maksudnya apa? Sebenarnya the results ni is not really diagnostic. But what does it tell us? Something's not right dengan brain dia. Ada dysfunction in the electrical charges of the brain. Itu je yang dia bagi tahu kita sebenarnya. Kalau you nak diagnose it as epilepsy, you still need to go back to the clinical. You don't diagnose TLE based on EEG. Diagnose TLE based on clinical. You added information from imaging and EEG to support. However, clinically at this stage, do we get a picture of TLE or seizure or not?
No.
So far tak ada. Okay, kita tak dapat clear picture of apa. Kalau you tengok kat sini bitemporal, bla bla semua ni, cortical semua ni kan. So it must at some point resort to generalized seizure. Tapi not in this case. Maksudnya kalau dia ada, betul-betul dia ada epilepsy, by now dia dah ada GTC. Mana if it's a focal seizure, by now it's already generalized dah. Tapi we have never observed him to have fitting, at least clinically. Okay, so neuromedical plan is to do MRI, lumbar puncture, virus screening, autoimmune screening, and ultrasound of abdomen and testicles. Kenapa dia nak buat MRI? Why do you want to do MRI?
Better assessment of the brain parenchyma soft tissue.
Okay. Alright. So we may not be able to see any gross. We may not see any gross intracranial masses dekat city brain, but kita nak tengok anything yang maybe require a more detailed view, such as MRI. So kita nak tengok that. Okay, so nak tengok any structural changes, any parenchyma changes, and any subcortical changes in the brain. Lumbar puncture, kenapa kita tengok lumbar puncture?
For any infectious causes.
Okay, so it basically we can see a lot of things kan. Maknanya sama ada infection, sama ada tumor cell, sama ada blood, benda-benda macam tu lah. So lumbar puncture. So he had his MRI today. Unfortunately, parents refused lumbar puncture. Virus screening still pending. Autoimmune screening, kenapa kita nak buat autoimmune screening? Kenapa kita nak buat autoimmune screening?
Cerebral lupus, doktor.
Okay, good. So kita nak tengok any neurological manifestation of autoimmune disease. So sama ada cerebral lupus ataupun autoimmune encephalitis. And so these are the things yang kita nak tengok. So still pending, fortunately. CRP normal, yang lain semua still pending. Ultrasound abdomen and testicles. Kenapa dia buat ultrasound abdomen and testicles?
To look for any tumor there that can seep to the brain.
Okay, good. So dia nak tengok paraneoplastic syndrome because of the age lah. So nak tengok any. So yang ni pending because unfortunately over the weekend dia develop fever. So dia develop thrombophlebitis. So he's in medical ward at the moment. Had course of antibiotics. So once he's well, then kita kena carry on balik dengan dia punya management. So apa kita punya current diagnosis now? Apa kita punya current diagnosis now?
Treatment resistant schizophrenia.
Treatment resistant schizophrenia? Kalau treatment resistant schizophrenia, kenapa kita nak buat LP, MRI, virus screening semua tu?
Medical,
Psychosis secondary to possible another medical condition not yet specified.
Betul. True. Okay, true. So that's our working diagnosis at the moment. Catatonia and psychosis for investigation. So maknanya kita still we still in the dark, but at least now we are macam tahu a little bit of, kita ada some direction. My gut feeling is this could possibly not turn up to be anything medical, and because kalau it's autoimmune encephalitis, meningitis, brain tumor, dia mungkin dah deteriorated much quicker. Tapi given that the symptom ni has proceed almost 1 year, looking back at the history, back in my mind, I think there is still possibility yang dia ni is actually treatment resistant schizophrenia. Tapi in the current state, until kita prove it otherwise, kita still kena maksudnya at the moment it still need to be considered to be medical until proven otherwise. Okay, so management at the moment, so kita carry on dengan all the investigation, and cuma medical management, psychiatric management, kita carry on with kita punya aripiprazole dengan metazepine. What I'm hoping adalah kita akan get the results sooner, and then we can actually know what we're dealing with our next direction, if it's schizophrenia, then maybe kita need to go pathway of clozapine, and tapi if not, then kita kena treat the, if it's otherwise, then kita treat the underlying cause dia lah. Okay, alright. So 5-18 dah. So what do we learn from the case?
It is not straightforward. We have to be vigilant and careful in taking history, physical examination, investigation, and be wide.
Alright, anything else? Anyone else not add anything?
Agree with Mohana.
Dr. Rozanizam.
Yes, saya. Ya, Nur Arif.
Saya not there. Saya sebenarnya nak tanya yang because for the indication for CT brain for that patient is because of young, so we can rule out the organic causes awal. Tapi example macam orang tu, adakah cukup dalam clinically saja kita boleh rule out? Sebab kita macam mana?
So, it's a clinical judgment, Arif. So same goes with macam you kata lah, macam kalau kita nak buat you suspect patient ada pleural PE. Okay, lama dah tinggal Amerika kan. Macam mana you nak decide CTPA, nak buat CTPA ke tak? Do you CTPA everyone that you suspect? Of course you need clinical judgment kan. Okay, mana you tengok risk factors, you tengok clinical presentation, you tengok onset, you tengok dia punya course, you tengok you punya history of treatment, respond to treatment, age, range, you tengok dia punya precipitating event, you tengok dia punya risk factors. So same goes with patient who presented with mental illness. So kalau 25 years old with history of cannabis use presented with psychiatric with psychotic symptoms, kita mungkin tak buat CT brain right away, and unless kita ada strong indication. And tapi in this case you cannot sit on schizophrenia. Maksudnya if you put down schizophrenia, adakah you akan rasa oh, I've satisfied, I have covered everything? No, you akan consider there are things that that is still possible. There are things that we have not yet excluded, and so that's probably one of the things yang kita kena consider bila kita manage case. So this is one of the examples yang maybe relates well bila you become a doctor one day. That is, not everyone comes in the textbook. You need to put together a lot of thoughts untuk you come up with differential diagnosis, management, and tapi we don't want you to be a doctors yang screen lah, alang-alang kita tak tahu apa ni, kita buat semua investigation yang ada. You need to justify yourself. Why do I want to do thyroid function test? Why do I want to do MRI? Kenapa kita tak buat lumbar puncture test masa dia present with depression, masa dia jumpa saya masa dia umur 13 tahun tu? Kenapa kita tak buat MRI masa tu? So maknanya again, you need to justify. Even if it's turned up to be autoimmune encephalitis, for example, looking back, would you change any of your initial management? And if you don't, maksudnya you've done enough. And if you're not, maknanya there are things that you should improve in your clinical practice. And so this is one example yang this isn't my success story lah, tapi saya nak share with you all. Walaupun dia bukan really adolescent, tapi issues of adolescent was there as well. Deep down, saya rasa case ni ada banyak psychosocial issues yang kita belum dapat selesaikan. We managed to speak with his father. We didn't get much information from the father. There was undisclosed tension between parents. And lepas tu, while he's in the medical ward, none of the family members stays with him. So there are things yang kita still tak grab dalam this whole case. And so what I'm hoping adalah you all boleh appreciate it. Satu is for your exam purposes lah. So we did discuss a few diagnosis and management, how to think along the line of psychiatric diagnosis. And second is for you to reflect on what you need to do as a doctor. So it's not easy. You need to be backed with sound knowledge. Remember, sometimes common sense is also another thing yang you need to integrate dalam your management, so that you know apa yang right and what necessary for your patients lah. Okay, so hopefully you all semua doakan my patients ni get well. Saya pun tak tahu nak buat apa dah dengan this patient. Maknanya of course lah kita tahulah nak buat apa, tapi we hoping that we get the answer sooner lah. Alright. Okay lah, dah 5:30 dah. Sorry for taking you quite sometimes in this afternoon. Siapa yang dah lost tu boleh catch up balik dengan your friends apa yang you miss out, and if there are any questions, last one question or maybe one or two, if there's anything. Kalau tak ada kita tangguh. Ada? Okay, alright. Thank you so much. I hope you learned something from this case. All the best if I don't see you around. Yang non-psychiatry posting, all the best for your final pro lah. Alright, thank you. Assalamualaikum.
Thank you, Doktor.
Thank you, Doktor.
Thank you, Doktor.
Dr. Rozanizam.
Thank you, Doktor.
Mana pergi end?
Thank you, Doktor.
Thank you.